I'm thrilled to introduce our next speaker, Dr. Cordina, who's going to be presenting about pulmonary vasodilators and single ventricles. It is 2:43 in the morning in Sydney, Australia, and Dr. Cordina is looking wide awake. She's a cardiologist at the Royal Prince Alfred Hospital in Sydney, Australia, and she's the vice chair of the Australian and New Zealand Fontan Registry. She's a world expert in pulmonary hypertension and will share her experience with pulmonary vasodilators and Fontan. Welcome, Dr. Cordina.
Thank you very much for having me. And if I don't make sense, yes, I admit I'm a little bit tired right now. All right, so most of you watching are probably pretty expert in the Fontan circulation, but for those of you who aren't, I just wanted to go over a few key features that are really essential for the rest of my talk. So first of all, of course, the Fontan circulation is the end result of a series of operations where the blue blood is bypassed away from the heart. So the superior and inferior vena cava connect straight onto the pulmonary arteries. And on this little diagram here, it's sort of simplified the Fontan circulation. So blood is pushed out of the ventricle at high pressure into the blood vessels. It goes through the systemic vascular bed and delivers oxygen to the organs, and then returns up to the systemic veins. And then it's here in this section where it meets the pulmonary vascular resistance, the blood vessels in the lung. And this circulation, because of that resistance in the lung, really exists in a state of high systemic venous pressure and low preload, so reduced blood flow into the lung. And that area there in red really acts as a bottleneck, and that is a core concept that I want you to understand. So that little bottleneck there causes back pressure. So the back pressure creates high venous pressure, and that's the driver for the things that Yoav was just telling us about. We also think that that high venous pressure drives end organ dysfunction and is partly explains why we have liver problems in the setting of the Fontan circulation. That bottleneck also underlies why we have reduced exercise capacity in the setting of a Fontan, for most people, not all, because of reduced blood flow into the lung. And that restriction of blood flow into the lung probably also causes some other important problems that I'll talk to you about in a minute. Now, blood flow in the pulmonary vasculature is very abnormal. On those black panels, you can see here in somebody with an extracardiac Fontan, I just have the echo probe sitting in the pulmonary artery, or the marker from the probe showing you the blood flow velocity. And you can see that it's laminar and very low velocity compared to this high pulsatile blood flow in one of our young trainees that we managed to convince to be a volunteer for these pictures. Now, when we do the Fontan operation and take away that pulsatile flow, we're completely changing the physiology in the lungs. And when we take away that pulsatile flow, the blood vessel development in the lungs really slows off or even stops altogether. So the blood vessels are intrinsically underdeveloped. When we take away that pulsatile flow, we're also taking away the shear stretch on the blood vessels, and that's very important for how blood vessels function. So the endothelium is very abnormal. And when you look down at the tissues, there are some changes there that resemble, they're not exactly the same, but resemble the blood vessels in people who have a problem called pulmonary arterial hypertension. We see intimal hyperplasia. Some studies have suggested that there's medial hypertrophy of the muscle layer in the blood vessel and in situ thrombosis. And at the cellular level, we see things like overexpression of endothelin-1, which is a really powerful vasoconstrictor, along with its receptors, and reduced BMPR2. These changes have all also been demonstrated in people with pulmonary arterial hypertension. So people started to wonder whether some of the medications for pulmonary arterial hypertension might also help our Fontan patients. There are also some Fontan-specific problems that also drive high pulmonary vascular resistance, such as very low oxygen levels. And some people have wondered about chronic subclinical venous thromboemboli, although most of you would be aware that the evidence has not demonstrated a benefit with full dose anticoagulation compared to antiplatelet agents. Now, it's well recognised now that adverse pulmonary vascular remodelling really contributes to the deterioration of the Fontan circulation. It drives up systemic venous pressures, it contributes to lymphatic dysfunction, and it also contributes to reduced cardiac filling. Something that we're just starting to understand, and we need to do a lot more work to characterise, is that that reduced filling of the heart probably also contributes to adverse cardiac remodelling. Just like if you underuse a leg muscle, the muscle doesn't work properly. People have hypothesised that that starvation of blood into the lung leads to diastolic and systolic dysfunction in the long term. That is an important problem in a number of our patients who aren't doing well late after a Fontan. So imagine if we could make that bottleneck bigger. We'd relieve some of the back pressure, reduce the high pressure in the veins, and we'd also improve blood flow into the heart. And so that led us to start thinking about the main pathways that we're targeting with drugs in pulmonary arterial hypertension. And those three main pathways at the moment, and I'm sure there's more to come, are the endothelin pathway, nitric oxide pathway, and the prostacyclin pathway. Now, the main drugs that we have at the moment that we treat pulmonary hypertension with are the endothelin receptor antagonists, which block the endothelin receptors, which, as I said, is a powerful vasoconstrictor. That's drugs like ambrisentan, bosentan, macitentan. There are drugs that work via the nitric oxide pathway, the phosphodiesterase inhibitors, which really augment nitric oxide effects. Drugs like sildenafil and tadalafil are most commonly used in pulmonary hypertension, but as many of you will be aware, there's a new drug called udenafil that has some very interesting data I'll tell you about in a minute. And at the moment, the drugs that are available that are prostacyclin analogues are not readily available as an oral drug, although there are a couple of really exciting things on the horizon. They're not studied yet in Fontan, but they're on the way. So initially, the data were really exciting. So there was a couple of studies showing that a single dose of a pulmonary vasodilator could improve exercise capacity. And that really generated a lot of interest, and there were a lot of case reports and small series published at the time. And the reason that we were so excited by that, of course, it's great if we make our patients feel better and they have better exercise capacity, but because we were using it as a surrogate endpoint, really, studies have shown us that our patients who can maintain exercise capacity or increase exercise capacity over time do better, have reduced risk for failure and death. And so many studies now are focused on peak oxygen uptake, peak VO2, which is a gold standard measure of peak exercise capacity, because we're using it as a surrogate endpoint. It is almost impossible in our rare Fontan population to design a trial that's adequately powered for us to understand the impact on survival or risk for failure. It's very, very difficult for us to have adequately powered studies. So we really have had to sort of default to these surrogate endpoints. And maybe that's been a little bit of an Achilles heel for us. So here I've listed some of the main trials over the last 10 years. There was a small trial in sildenafil that did not show an improvement in peak VO2, but it was only small. And it did show an improvement in myocardial performance index, which is a global measure of heart function measured with echo. There was an open label bosentan study that again didn't show an improvement in peak exercise capacity. But the TEMPO trial, which was the most robustly designed and largest trial, did demonstrate a small improvement of around 5%, which one might argue isn't especially clinically significant, but we definitely thought it was worth looking into further. it's important to mention too that there's a whole bunch of series and case reports of these drugs, particularly the phosphodiesterase inhibitors like sildenafil, being used in patients who are failing or not doing well or have protein-losing enteropathy. And that's certainly my experience, and I know others I've spoken to as well, that we do have specific patients who really do seem to stabilise when we use these drugs. And that's not really been borne out in these little trials. This is the largest study that I'm aware of that actually measured hemodynamics in a group of people that were given pulmonary vasodilator therapy. So this group took 24 children and adults, but they selected patients who had a high pulmonary vascular resistance index. So a PVRI of 2 might not sound that high to you, but in Fontan physiology, that is a high PVR, and that has been associated with poor outcomes. And after 6 months of either bosentan or macitentan, the PVRI fell by, on average, 30%, which is really massive. But interestingly, there was no overall impact on exercise capacity. So again, you know, we really need to work harder to understand what these improvements in hemodynamics mean for our patients and how we can, you know, which endpoints are the right things that we should be studying. And then, of course, there is the absolutely epic sildenafil trial. Hats off to David Goldberg. This was massive, 400 patients. They were young, 12 to 18 years of age. And important to note that these were pretty good Fontan people. They excluded people with a peak VO2 of predicted under 50%. So we're not looking here at a group of sick people with a Fontan circulation. Somewhat disappointingly, peak VO2 did not change significantly, although there was a tendency and perhaps they were underpowered. There was an improvement in peak VO2 at AT, and the myocardial performance index, that global measure of heart function, did improve significantly. Although there weren't really serious side effects, adverse effects were common. And I'm just not sure yet that this data is enough for us to be putting every single one of our Fontan patients on these drugs. I'll be interested to hear what the opinion of the audience is. It's winter here in Australia, and this was a picture of my daughters trying to climb a sand dune at the beach on the weekend, and it kind of reminded me of our attempts at clinical research in this area, and there's been some pretty crap attempts, but overall we're making progress and we're getting there. And I think it'll be really important for us to delve down into the fuel trial and try and understand which phenotypes, which of our Fontan patients seem to be the responders. There's a big trial coming, and I think a lot of what I'm telling you now will probably be outdated soon. The Rubato trial, which was macitentan for adolescents and adults with a Fontan circulation, has finished recruiting, and I think we're going to hear about those results really soon. And again, having a big data set for us to look at and understand who are the patients who respond to these treatments the most, so we can design clinical trials better down the track is really going to be next steps. I can't give this talk without reminding you all that of non-invasive therapies for the Fontan circulation that have been studied in a controlled trial, exercise is still the most effective treatment to improve exercise capacity and improve cardiac output. And we really do need to be incorporating exercise into our clinical care pathways for our patients. So in conclusion, I think there probably is a subset of patients who will really derive benefit from pulmonary vasodilator therapy, but I think phenotyping or understanding our patients more deeply is really important. And I'm not sure personally that there is a role for every single Fontan person. And the impact at the moment on late outcomes is unclear. And we need to think about, you know, international collaboration and large registries with long-term follow-up so that we can address that in the future. Thank you.
Excellent. Thank you very much, Dr. Cordina. This is a fantastic presentation reviewing the effects of pulmonary vasodilators in Fontan. From the chat function, everyone really enjoyed your presentation, and I'm going to use the M&M analogy in every future discussion about this topic. We have time for one question that came from the audience. How do you ensure that your patients stay active and exercise during this COVID season with all the restrictions?
Yeah, that's a really great question. I think partly it depends where you are in terms of whether you're allowed out of the house for exercise sessions and for how long. We are also encouraging people to use the internet. There's some really fantastic tools available to people now, more than ever really, to do home exercise. Now, I think cardio exercise is a little bit difficult unless you're sort of following along with a program or a class. We encourage, or I encourage my patients to get some home resistance bands, which are really, really cheap. And it's a really easy way to be doing some strengthening exercises while you're at home. And there's lots of YouTube videos and things that you can use as well. But yes, it's challenging at the moment. It's an unprecedented time.